Now we're going to do the physical exam for the foot and ankle. So we can inspect the foot and ankle and look for things like bruising or swelling or deformity. And then we can also palpate at the ankle. Palpation is going to be important as it's also one of our special tests. You guys will learn a little bit more about the Ottawa foot and ankle rules, but those are important findings that we need to look for if we want to determine whether or not we want to get an x-ray series and an acute injury. So for the Ottawa ankle rules, if you have pain in either of the spots that I'm going to palpate in a second, or you're not able to take more than 4 steps in the emergency room or in the office after an injury, that would be a reason to get an x-ray. Same as with the Ottawa foot rules, it's just different locations for palpation. So areas that we want to palpate on the ankle for the Ottawa ankle rules are going to be the posterior aspect of the medial malleolus and 6 centimeters up from that, and then the posterior aspect of the lateral malleolus and 6 centimeters up from there. So those are our 2 Ottawa ankle rule locations. Our 2 Ottawa foot rule locations are going to be the navicular, which is a bone here on the inside part of the foot. The easiest way to find the navicular on a physical exam is to start at your medial malleolus and palpate down to your next bony landmark in the foot, and that's where the navicular sits. So we want to palpate across the navicular, and then our other Ottawa foot rules location spot is going to be the base of the 5th metatarsal. If you palpate along that 5th metatarsal, all the way up to the proximal aspect, you're going to get to a point where your finger falls off into this soft space. Right there at the end of the bone is the base of it, and that is where you want to palpate for this. So those are our Ottawa foot and ankle rule locations. With the rest of our physical exam, we can go into range of motion, so the terminology is a little bit different. We can dorsiflex, or pull our toes towards the ceiling, and plantar flex, and point our toes towards the floor. Our foot also inverts and everts. This is something that I like to do passively, so we can see that tilting motion here of inversion and eversion. That's our range of motion, and you could do strength testing in those planes as well by having the patient push their foot down into your hand like they're pushing on a gas pedal, or lifting up towards the ceiling to test strength there. We have 2 other special tests that we want to go over for the ankle exam. Both of these would be looking for a ligament injury at the ankle and are testing for ankle instability or ankle laxity. So our first test is the anterior drawer test. For this, I'm going to put one hand on the end of the tibia, and the other hand I'm going to put on the bottom part of the calcaneus, and I'm going to slide the calcaneus towards me. So I'm providing an anterior force on the calcaneus. So you can see me trying to pull it forward. It's not going anywhere because all of her ligaments are intact. We could also look for pain with that test too, but the biggest thing that you're looking for is looseness or laxity. Our other test that we're going to do for this is the squeeze test. Here we're going to be squeezing at the more proximal aspect of the tibia and fibula, squeezing them towards each other, looking for pain at the ankle joint. If the patient has torn ligaments on both the inside and the outside part of their ankle, they are going to have laxity here, which is going to cause these bones to spread apart when we're squeezing up here at the top of the leg. So if you squeeze here and our patient has pain at the ankle, that would be concerning for a ligament injury.